Since introducing high-sensitivity troponins, the frequency of reporting elevated troponin results has increased significantly. How do I tell if the elevated troponin level is due to MI or not is our topic today. Let's start. Myocardial infarction produces clinical symptoms, EKG changes, and elevated troponin levels. Troponin elevation in acute MI has two important characteristics. They are detected 2 to 3 hours after myocardial ischemia. In other words, 2 to 3 hours after the onset of MI symptoms. In most cases, troponin elevation in acute MI follows a pattern of a rise to a peak and then a fall. They don't remain stagnant. This is a stark difference between troponin elevation in MI and most non-MI causes. Assessing elevated troponin starts by taking a careful history, asking for any MI symptoms, and then reviewing the EKG. The absence of MI clinical symptoms and acute ischemic EKG changes effectively rule out MI even if troponins are elevated. The presence of MI symptoms and the absence of EKG changes should raise the questions of whether another diagnosis is more likely. If not, proceed with MI treatment until proven otherwise. EKG changes in acute MI are beyond the scope of this video and requires a separate one. I have 9 real-world clinical examples that will make this topic easier to understand. But before that, if you would like to receive a summary of this video and access previous video summaries, kindly subscribe to my Substack page. The link is provided below. Let's start with the first example. A 54-year-old lady presented with acute low back pain. Troponin levels was ordered and came back elevated at 190 nanogram per liter. The upper normal limit in my facility is 50. And this will apply to all examples from now on. The EKG was negative for ischemic changes. Is this an MI or not? MI symptoms are absent here. Low back pain has a low pretest probability for MI. Along with negative EKG, this effectively rule out MI in these patients. Not sure why troponin level was ordered here. Of course, now we had to trend troponin levels and they came back as 200 and then 165 nanogram per liter. The patient underwent an echocardiogram, which was unremarkable. Then the patient was discharged home without any further workup. The lessons we learned from this case: avoid ordering troponin levels inappropriately when the pretest probability for MI is low, and notice here the stagnant nature of troponin levels. There was no significant rise or fall. Let's move to the next example. The other night, actually, I saw a 73-year-old lady with a history of coronary artery disease and had a history of RCA stent placed 5 years earlier. She presented with chest pressure 5 out of 10 radiating to her jaw and similar to the pain she had 5 years ago. She got concerned and came to the ED to be checked out. The patient's EKG showed a subtle isolated ST elevation in AVL and a reciprocal ST depression in lead 3. The first troponin was 1000 nanogram per liter. Again, the upper normal limit was 50. Is this an MI or not? Now, just hearing the history makes the likelihood or pretest probability of ACS or MI is very high even before reviewing the EKG or the troponin results. Unlike the previous example where low back pain has a low pretest probability for AMI or acute MI. Here is the patient has a full constellation of acute MI with clinical symptoms, EKG changes, and elevated troponin levels. She was treated, of course, per ACS protocol. I actually argued with the ED and cardiology that the cath lab should have been activated earlier based on the EKG changes and symptoms. Cardiology was not convinced until the next troponin set came back at 7000 nanogram per liter. The patient underwent coronary angiogram, which surprisingly revealed patent stents and clean coronaries otherwise. She was diagnosed later on with acute myocarditis following a recent upper respiratory tract infection. The third troponin was 4000 nanogram per liter. The lessons we learned from this case: the pretest probability for acute MI was very high in this case, and any elevated troponin level is due in such case is due to MI until proven otherwise. If an acute MI is suspected based on symptoms and EKG changes, the treatment must be started even before the troponin level is back. Myocarditis is a great mimic for acute MI that's difficult to distinguish without a coronary angiogram. Similar to myocarditis, we have coronary vasospasm, spontaneous coronary artery dissection, and tachycardiomyopathy. All these are great mimics of MI as well. Notice also the rising and falling patterns of troponin in this acute MI case. Let's move to example 3. A 45-year-old gentleman with no significant past medical history presented with a sudden onset of severe, sharp, knife-like chest pain, causing the patient to seek medical attention immediately. EKG showed sinus tachycardia at a rate of 130, no ST segment or T wave ischemic changes. Initial troponin was 90 nanogram per liter. Again, the upper normal limit was 50. Is this MI, acute MI or not? Now, the sharp stabbing or knife-like pain should immediately raise an alternative diagnosis to acute MI. And immediately comes to my mind aortic dissection. That comes to my mind first. It must be ruled out before thinking even of acute MI, which was ordered confirmed a type A aortic dissection. The patient was taken for emergent surgery. The second troponin set was 200 nanogram per liter. There was no third one obtained. Lessons learned from this case: history remains the single most important part of making the correct diagnosis of acute MI or not. Sinus tachycardia is not common in acute MI except if there is associated cardiogenic shock. You would expect some major ischemic EKG changes in this case had this patient pain caused by an acute MI, given the severity of the chest pain. And notice the mild increase in troponins, which can happen in aortic dissection. Aortic dissection by itself can cause troponin leak. Let's move to example number 4. A 69-year-old gentleman with a history of anterior wall MI a year ago. Stats post stenting to LAD presented with worsening exertional shortness of breath and lower extremity edema over the last 3 weeks. The patient's O2 sat on room air was 86% and improved to 96% on 2 liter per minute O2 via nasal cannula. EKG showed Q waves in V3 and V4 and non-specific T wave inversions in lead 3 and V1. Chest X-ray showed findings suggestive of pulmonary edema. First troponin was 200 nanogram per liter. BNP was 950. Is this an acute MI or not? Again, it's pretty obvious here that we are dealing with a congestive heart failure exacerbation, probably due to ischemic cardiomyopathy, given the previous MI and the presence of the Q waves and the absence of acute ischemic changes. The patient was started on IV diuresis. Ejection fraction was found to be 25%. The next 2 troponin sets were 250 and 195. Lessons from this example: many cardiac and non-cardiac conditions cause MI-like symptoms, and history and physical exams are essential to distinguish between them. The presence of pathological Q waves without ST segment and T wave changes are the sequelae of an old ischemic event, not an acute ischemic event. Notice the very small rise and fall in troponin, again, unlike acute MI where we see a significant rise and fall. Congestive heart failure patient may have a chronically elevated troponin levels even in the absence of myocardial ischemia. And interestingly, these patients carry worse prognosis compared to congestive heart failure patients without elevated troponins. Let's move to the next example. A 39-year-old diabetic, non-compliant lady with end-stage renal disease on hemodialysis. She missed her last 3 hemodialysis sessions and presented with shortness of breath and confusion. In the ED, she was hypertensive with blood pressure of 190 over 110, heart rate 110. O2 sat was 85% room air, quickly corrected with 3 liter of O2 via nasal cannula to 94%. Blood sugar was 199. Chest X-ray showed findings suggestive of pulmonary edema. EKG showed new left bundle branch block not seen on the EKG from 2 months ago. Initial troponin was 300. Is this an acute MI or not? Similar to the previous example, the CHF example, this patient's shortness of breath is obviously due to pulmonary edema from non-compliant with hemodialysis. But how about the new left bundle branch block? There is one critical piece of info missing here in the question. Can you guess what? Yes, the potassium level was 8.5 milliequivalent per deciliter, which explained the new left bundle branch block. This patient underwent emergent hemodialysis. The next troponin set was 350 and then 290. Potassium went down to 6.5 post hemodialysis, and the left bundle branch block resolved. Lessons learned: Hyperkalemia may mimic acute MI EKG changes. Similar to CHF, a renal patient may have chronically elevated troponin level in the absence of myocardial ischemia. These patients carry again worse prognosis compared to renal failure patients without elevated troponins. And again, notice the pattern of troponin rise and fall here. Let's move to example number 6. A 75-year-old patient was brought to the ED after he woke up with an inability to speak and right-sided weakness. He was seen okay the night before. CT brain in the ED was negative. EKG showed T-wave inversion in lead V3 through V6. Troponin levels was 190 nanogram per liter. Is this an acute MI or not? Again, look here, the pretest probability of acute ischemic stroke is very high based on the symptoms. There is no reason to suspect acute MI. But what about the EKG changes and the elevated troponin levels? Stroke and acute neurological conditions are known to cause ischemic-like EKG changes and elevated troponin levels in the absence of myocardial ischemia. The patient's MRI confirmed an ischemic stroke in the right MCA territory, and the next two troponin sets were 182 and then 165 nanogram per liter. The echocardiogram was unremarkable. Lessons learned here: stroke and acute neurological conditions may cause ischemic-like EKG changes and elevated troponin levels. And again, notice the stable level of troponins on serial testing. Let's move to the example number 7. A 51-year-old alcoholic patient presented with severe epigastric pain that started 2 hours before the presentation to the ED. CT scan of the abdomen showed edematous pancreas and surrounding inflammatory changes. Lipase level was elevated at 1300. EKG showed sinus tachycardia at 140 with ST depression in anterior leads. Initial troponin was elevated at 310 nanogram per liter. Is this an MI or not, acute MI or not? Again, this is another obvious case. The patient has acute pancreatitis. The ST depression on the EKG is likely due to sinus tachycardia, and probably the troponin elevation was likely related to tachycardia and demand ischemia, or what we call type 2 MI. This patient was diagnosed with severe alcohol-induced pancreatitis and received aggressive IV fluid resuscitation. Serial troponin were 400 and then 320 nanogram per liter. The echocardiogram showed no wall motion abnormalities. Lessons learned here: similar to stroke, acute pancreatitis may cause ischemic-like EKG changes in the absence of myocardial ischemia. Tachycardia, when severe, or any tachyarrhythmias often lead to ST depression. Demand ischemia or type 2 MI happens when there is a mismatch between myocardial oxygen supply and demand. The treatment of type 2 MI should be addressed to the underlying cause. Now, demand ischemia happens with decreased supply, as in hypoxia and hypoperfusion, regardless of the underlying cause, or increased demands, as in tachyarrhythmias, LVH, RVH, or HOCM, hypertrophic cardiomyopathy. Let's move to the next example, example 8. An 81-year-old gentleman presented to the ED with severe shortness of breath. Initial vital signs were blood pressure 70/40, heart rate 170, O2 sat on room air was 55%, respiratory rate 39, EKG showed AFib with RVR and diffuse ST depression. The patient was placed on 100% non-rebreather mask and underwent immediate cardioversion. IV fluid resuscitation started simultaneously. The patient converted to normal sinus rhythm at a rate of 92 and ST depression had resolved. Blood pressure improved to 100/60. O2 sat was 99% now after cardioversion, 100% non-breather mask. Patient's shortness of breath improved significantly. Chest X-ray was unremarkable. Initial troponin post-cardioversion was 400 nanogram per liter. Is this an acute MI? Again, the patient has AFib with RVR and hemodynamic instability. Immediate synchronized cardioversion is the best next step. Now, post-cardioversion EKG showed no ischemic changes, and the initial elevated troponin level was possibly due to a combination of demand ischemia from the tachycardia and hypotension and the cardioversion procedure itself. The ED physician was still concerned because he believed the elevated troponin levels were higher than typically expected for demand ischemia and post-cardioversion. The patient was initially admitted to the ICU, given a full dose of aspirin and started on a heparin drip, which he needed anyway as he underwent cardioversion from AFib rhythm. Serial troponins levels were 500 and then dropped to 420 nanogram per liter. and echocardiogram showed EF of 35%. The patient was evaluated by cardiology and discharged a day later on oral amiodarone, apixaban, metoprolol, and lisinopril with cardiology outpatient follow-up in 1 week. The lessons we learned here: cardioversion, defibrillator shocks, ablation, pacing, cardiac contusions, and surgery may cause some troponin elevations. When in doubt and you cannot decide if it's an acute MI or there is an alternative diagnosis, treat it as MI until proven otherwise. Most non-MI causes of elevated troponin levels cause modest, stable, elevated troponin levels, but significantly high elevated troponins with significant rise and fall strongly suggest MI, but again, it's not diagnostic. Tachycardia-induced cardiomyopathy improves with medical management and adequate rate control. Again, tachycardia and hypotension are common causes of demand ischemia. Let's take one more example. A 62-year-old lady presented to the ED with syncope at a local shopping center. I only saw her the next morning and was signed out to me as a syncope case with mildly elevated troponin levels. The admission EKG was reported to be negative. 3 sets of troponin overnight obtained 3 hours apart was 60 and then 102, then 178 nanogram per liter. When I interviewed the patient, I noticed she was on 4 liter of O2 by nasal cannula, and she doesn't use oxygen at home. Her chest x-ray was unremarkable, and I always teach my resident that hypoxia not explained by a chest x-ray should raise the suspicion of pulmonary embolism. Upon further questioning, she told me that she's been having exertional dyspnea for a week and remembers syncope, shortness of breath, hypoxia, and negative chest x-ray all raised the suspicion of PE. Chest CTA showed a large burden of right-sided PEs. The patient was started on anticoagulation at this point. It was obvious that the elevated troponin levels were due to PE and right ventricular strain. The lessons we learned from this case that hypoxia, regardless of the underlying cause, may lead to elevated troponin levels that are usually modest, and RV strain may cause troponin leak. In the end, a cardiology consultation is not mandatory in every case of elevated troponin levels, particularly in obvious cases. Finally, I will leave you this table that lists all the possible causes of elevated troponin levels, of course non-MI causes. But before that, remember that you can get a summary of this video and previous videos by subscribing to my Substack page. If you found this video helpful, please give it a like, share it with your colleagues, and subscribe to the channel if you have not done so. Thanks for watching, and see you soon.